Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado Anschutz Cancer Center. I'm going to walk you through some of the key trials that have led to FDA approval of newer agents, and that has certainly unleashed a whole new toolbox in patients for us to treat patients with relapsed refractory lymphomas. I think the third promising advance, in my opinion, has been with the advent of bispecific antibody treatments, also called BiTEs. So bispecific antibody targets CD20, and bispecific antibodies are IV infusions that are given over a certain period of time. There are about 4 bispecifics currently being investigated. However, the front runner has been Mosunetuzumab. Mosunetuzumab is a CD20 BiTE that has been given and tested in patients with relapsed refractory lymphoma and has shown exceptional responses, especially in patients with relapsed refractory follicular as well as relapsed refractory diffuse large B-cell lymphoma. FDA approved mosunetuzumab in late December 2022 for patients in the third-line setting who have failed 2 lines of treatment with relapsed refractory follicular lymphoma. Mosunetuzumab has an exceptional overall response rate with a CR rate of nearly 70%, with a median PFS of over at least 17 months, with a very manageable toxicity profile. Since this is an immunotherapy, one needs to consider unique side effects of immunotherapy, for example, cytokine release syndrome, as well as ICANS or neurotoxicity. Cytokine release syndrome was seen in mosunetuzumab, but one can mitigate it by giving the step-up dosing. As a result, as long as we have the resources to take care of these unique side effects, which most academic centers as well as community practices do, I think mosunetuzumab is there for prime time for a lot of us as one of the other tools to treat patients with relapsed refractory follicular lymphoma. For patients with relapsed refractory follicular lymphoma, there are several options. We have agents such as lenalidomide plus rituximab. We have agents such as tazemetostat. We have CAR T-cell therapy with tisagenlecleucel and axicabtagene now approved in the third-line setting. And now we have mosunetuzumab in the third-line setting. Mosunetuzumab and CAR T-cell therapy are all time limited. As a result, the biggest question is, if a third-line relapse follicular patient came to you, then which one would you actually offer? I think it would certainly be a conversation with the patient, and based on the resources that are available, the level of commitment, the ability to tolerate CAR T versus not, I would say those would be some of the things, especially also the tumor characteristics, meaning patients who are actively symptomatic with a high tumor burden, high LDH, they potentially won't be able to wait for CAR T-cell manufacturing. I think in those patients, mosunetuzumab, which is an off-the-shelf BiTE, will come in absolutely handy. It's a time-limited strategy with a durable long-term remission. And I think this will be certainly something that we will see very quickly being lapped up in clinical practice.